slide shared by various specialists in various conferences. Um, I hope you will do better by the end of the session. Okay, this is just a brief comical slide to tell you why ECG is important and why interpreting it properly can be useful, even if you're not a cardiologist. So, ECG basics. Very quickly, I'm not going to do too much pathophysiology here. Sinus node is what generates an ECG, although we know that every part of the heart can generate an ECG, but sinus node is quicker than the others, so it takes over from everything else. Electricity, so this is like a battery. It's conducted to the AV node. So AV node is what controls the heart rate. It defines at what speed the conduction is going to go down to Purkinje fibers and all the bundles. So if this is a battery, this is a toll plaza. Okay. In the normal parts of the ECG, you have a P wave followed by a QRS complex, this ST segment leading into a T wave. Okay, so two other things to remember. Always look at the speed, look at the voltage. So the speed should be set at 25 millimeter per second. Speed is in the horizontal axis and the gain is in the vertical axis. So 5 squares, 1, 2, 3, 4, and 5. 5 squares is equals to 1 second. One large square is 0.2 seconds. Something to remember, okay? Normal bits of ECG, the PR interval should be between one large square. So one large square is 200 milliseconds or just over 220. So PR interval is 0.12 to 0.2. So 3 to 5 small squares or one large square. QRS duration, which is this bit, QRS duration, it should be less than 110 or even up to 120 will be acceptable, which means 1, 2, 3 small squares. Okay, so just remember that. One large square for PR interval, 3 small squares for QRS or just under 3. And then QT interval will come to later, but just remember difference in males and females up to 460 milliseconds or 0.46 seconds in females, 0.44 in males. And we'll touch base on this later. This is an important slide to understand. These are chest leads V1 to V6, which are attached on the front of the chest moving towards the left axilla. V1 attached on the fourth intercostal space on the right, V2 on the left fourth intercostal space, then V4 is in the mid-clavicular line, fifth intercostal space, V5 anterior axillary line, V6 mid-axillary line, and V3 is halfway in between V2, V4. Why is this slide important? Because what I want you to understand here is that the heart, as you can see at the back, is sitting in the middle of the chest and not like this diagram, but it's slightly towards the left. So V1, V2 are looking at the front of the heart, and on the front of the heart you have a right ventricle usually, and as you move from V3, V4, V5 into V6, you're looking at the lateral aspect of the heart, anterior and lateral. Okay, so anterior, lateral, that's how you're going, because it's a three-dimensional structure and different leads are like different cameras looking at the same object from different angles. That is why they look a bit different, and this concept will be repeated again and again as we go along today's presentation. These are limb leads, 2, 3 AVF and 1, 2, 3 and AVR, AVL and AVF. So here what I want you to notice is AVF and leads 2 and 3. Okay, AVF and 2 and 3. These two are looking at the heart from the bottom end. Okay, so they are looking at the inferior aspect of the heart. AVL and lead 1 are looking from the lateral aspect, from the high lateral area. And AVR is the only one which sits on the right here, and it has a limited role but a very useful role. I'll explain that later. So this is just a concept. So going back again, V1 to V6, you're looking at the heart from the right, anterior, anterior septum, lateral, and inferiorly 2, 3 AVF, 1 and AVL laterally. Why is it important? Because if you put the leads in the wrong position, you start to see things which you should not be seeing, or you don't see what you are meant to see. For example, if you move the leads 1 or 2 spaces above and start attaching here, the heart will look different from that angle. So the ECG will change, and you may induce unnecessary or unintended T-wave inversions. Or if you move it too much here, then you can, change the lead amplitudes. And for example, if you attach this to the wrong end, you can bring axis deviation for no reason. So it's very important that the lead position is correct. So let's look at some examples. Straight to cases. This is all the basic I have to do. Can you all hear me still? Because at this stage, we're going to become a bit more interactive. This is your first ECG.
Yes, I don't know, but some background noises
Some
are
noise.
coming.
Okay.
Background noise.
Everyone, please mute unless you will be talking. Thank you very much. Thank you. That's brilliant. So now on
That's
this,
better.
thank you. So what we're going to do on this ECG, it says on the top it's normal ECG. So no points for telling me it's normal. Okay. We are going to go through a sequence of how we should approach an ECG, even if we don't know what's wrong with it. So I want you guys to one by one tell me what are the things that you should be looking at or trying to report on whenever you're asked to look at an ECG. So any one of you can just unmute and mention one thing, then let someone else mention the other. For example, heart rate. Okay, that's I'm just giving you an idea. So go on then. Just tell me first what you guys have in your mind.
Regular interval.
Okay, no, I'm not asking for interpretation. I'm saying what are the things you have to go through. So,
Uh, Rate, rhythm,
okay, just one each. So rate, yeah. Okay, you've done rhythm as well. That's fine. And
Access,
access. Okay, something else. Anybody else?
Hypertrophy.
PR interval,
PR intervals, good. What else?
Hypertrophy.
Okay, so that's voltage amplitude you're talking about in terms of hypertrophy, yeah? Okay, what else?
ST depression or elevation,
So ischemic changes, yeah? Okay, anything else?
Fatigue excess.
regularity,
Access, yeah. Regularity, good. Is it regular or irregular? Okay, what else?
Any pacemaker.
Yeah, okay. So presence or absence, but if you see it, what else? Someone
shape
said
of QRS complex, shape and broad or
QRS.
narrow.
Yeah, QRS complex. So it's broad or narrow. And the other thing you can see is, okay, here, if you notice, so from V1 to V6, remember I said you're looking from the right side of the front of the heart, moving towards the lateral side. Remember that picture? So the QRS complex is negative usually, V1. V2 is also negative, yeah, negative is downwards, 3 negative. But at V4, 5, 6, it starts to become positive. Positive means it's going up. So this is one thing to also remember. V1 to V6, this is what we call R wave progression, going from negative towards positive. That's also something to keep in mind. Okay, look for that. Fine. And T waves, T wave inversions, T wave morphology. Okay, so in this ECG, I'll take you through this one. The speed is correct, voltage is correct. Other thing to remember is patient identity. In clinical practice, always make sure it's a right patient. The name should be on the top. Never ever report an ECG for someone who the ECG which does not have any label on top. Okay. So first thing first, you also have to define whether this is a sinus rhythm. By sinus rhythm, we mean presence of P wave. Okay, so if there's a P wave that's present, that's sinus rhythm. So we've defined the rhythm as sinus. Then we say if it's regular or irregular. So for regularity, the bottom strip is called the rhythm strip. Okay, there you have 1, 2, 3, the other limb leads, chest leads, but the bottom strip is a rhythm strip, and this number 2 means that this is lead 2 printed throughout the length. Okay, you can change that if you want, but by default, lead 2 is printed as a rhythm strip, and here this gap